Okay, welcome everybody. Welcome to our December rounds. Today we have Dr. Miles Sargent with us. He is a family physician who has worked with vulnerable populations, including those experiencing homelessness and/or addictions, the elderly, for over 25 years. He's recognized the intersection between environmental issues and health, and he's dedicated himself to addressing the climate change issues and has co-founded partnerships for environmental action by clinicians and communities for healthcare facilities. The charity Trees for Hamilton as well in 2012, and the not-for-profit Shelter Health Network in 2005. And he's now the executive director of the Canadian Coalition for Green Healthcare. Welcome.
Thank you, Kathy, and thank you for having me today. And thanks everybody who has jumped on. So the topic, environmental sustainability in Canadian hospitals. This is more hospital focused today. Next slide, please. McMaster University recognizes and acknowledges it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. The Dish with One Spoon reminds us that we should only take from the land what we need. Next slide. So these were the objectives. Kathy, I believe these were sent out. Yeah, so I won't review them now. Go ahead. Disclosures. I don't have a lot of disclosures in this climate space. Not a lot of money. I do have two roles which pay me a half a day per week. One is with McMaster teaching the residents, and the other is with the Hamilton Family Health Team. Green Initiative did make a bit of money last year from Environment and Climate Change Canada for a project that we did. Otherwise, I'm pretty innocent. The other disclosures that I do love trees, and of course I love the planet. Next slide, please. So planetary health, bit of a buzzword. What does it mean? I often ask people to sort of reflect on that and have them put things into the chat. I'm not going to ask you to do that today. But what is planetary health? There may not be one fixed definition, but here are a few. Next slide, please. So essentially, planetary health is the intersection between human health or medicine and all of the environmental sciences. And obviously, I'm at McMaster. There are a lot of ologies to study in the science department at McMaster. So it really is a massive, massive field. I've given 3 definitions of planetary health here. The Lancet's might be the nicest one. Definition B, planetary health is the health of human civilization, the state of the natural systems on which it depends. And I like to dumb everything down. My definition, how we impact the environment and how the environment impacts us. Next slide, please. So the point I always like to make for people who don't think about this as much as I do is that if you were to Google planetary health or top 10 environmental problems within environmental health, this happens to be a website that I'm using here, Blue and Green Journey. The top 10 usually look the same. This is the usual mix. All of these things are clearly very important. And look, you're welcome to have my slides later if you don't have time to read through all of this. The big point for me is that it is number one, it's global warming and climate change, which is our most urgent issue. And the reason I've put it in red and the various words around there that are in red are where global warming, the rise of CO2 intersects with all these others in the top 10. That's why I focus on it. Next slide, please. So more specifically, I talk about sustainable healthcare. The World Health Organization definition of sustainable healthcare, a health system that improves, maintains, or restores health while minimizing negative impacts on the environment and leveraging opportunities to restore and improve it. Next slide, please. So the question I like to ask the med students, bit of a misleading question, but what is the basic unit of measurement for global warming? We are, after all, scientists as physicians. It's good to have a unit of measurement, and it's not actually temperature. Temperature would be an indirect measurement. Next slide, please. The measurement we use is CO2. This is an Environment and Climate Change Canada slide. I have added the parts in red here. So the term global warming potential, so each greenhouse gas has a global warming potential, and the base unit is the global warming potential of a carbon dioxide molecule. And if you multiply that out, you can see how it measures up with the other typical greenhouse gases that we see within healthcare. So methane from food waste, 83 times worse than CO2 in terms of its global warming potential. Nitrous oxide or laughing gas, 273. And desfluoride, I'm sure you've all heard about this, anesthetic gas, 2,500 times worse than CO2. Next slide, please. So despite CO2 being a relatively small molecule in its global warming potential, there is so much CO2. It is the dominant greenhouse gas. It's, depending on what you look at, 65, 70% of all the greenhouse gases. This is looking at the rise of greenhouse gases from 1990 to 2015. Carbon dioxide in green. Increasing methane, interestingly, on this graph is staying about the same in orange. Nitrous oxide creeping up a little bit. But you get the idea. The main greenhouse gas is CO2 from the burning of fossil fuels. Next slide. There's something called a life cycle analysis. This is something which engineers do. You can look at every product that we produce, manufacture, and use, and do a life cycle analysis of that product. And that essentially looks at the product, if we're talking about a mask, from it being dug out of the ground to being shipped to manufacturing, shipped to packaging, shipped to us. We use the mask for however long, as you all know, can be quite short. Then we throw it out, it goes to the dump or to incineration. That is the life of the mask, and the global warming potential of one mask is 0.02 kilograms of CO2. Big deal. Next slide. And this, of course, is why it is a big deal. This is Maria. She is an artist from the Netherlands. She's given me permission to use this slide. Her website's in the bottom right. She asked her surgeon, and she had breast reconstruction surgery done, which is a long surgery. She asked her surgeon if she would keep all of the waste from that surgery, and this is the waste from one operation. Next slide, please. So then it becomes less surprising that healthcare does account for 5% of our national carbon footprint. And if you think of all the cars we drive personally, the houses we live in, all the different manufacturing sectors out there, healthcare being 5% is clearly an oversized footprint, more than the airline industry. We can do better. Next slide. If I was to take that graph I showed a minute or two ago with the green CO2, it would fit precisely from the bottom left there at 0, or actually, sorry, 1990 across to 2015. That fits right in there. So that is the greenhouse gas contribution, represented here just by one black line, going up from 40 gigatons of worldwide global greenhouse gas over a 30-year period to 50 gigatons, plateauing during COVID for reasons you can understand. You've heard about getting to net zero by 2050. You can see 2050 on here. We need to follow that green or aqua colored line at the bottom. These are obviously futuristic scenarios. In pink, if we do nothing and the greenhouse gas continues to rise, what temperatures we'll have. So we need to follow that green line. We need to actually decrease by 50% in the next 6 years. That's going to be tough, but I am actually very, very optimistic that we are heading in the right direction. Next slide, please. So healthcare does contribute 5% of the greenhouse gases, and greenhouse gases in turn impact our health. These are all photographs from newspapers in the last 3 years in Canada. That is Hurricane Fiona, Newfoundland, top left. Don't need to tell you, hurricanes used to just be something we'd see in the southern states. Moving further north, fires, of course, this could be any number of places in Canada. I think this one is BC. Top right, tornado outside of Ottawa. Bottom left, Calgary, flooding. And then the bottom two on the right there are the heat dome in BC, which killed over 600 people that week of the heat dome. Next slide, please. So here is a simple visual of the impacts of climate change on human health. So again, if you think back to that planetary health slide of the top 10 things impacting the environment, this is focusing on number one. Again, this is global warming and climate change. And so this is Jonathan Patz, who's a professor, I think physician in Wisconsin, who made this. Within the middle, rising temperatures, weather changes, and rising sea levels, and then moving out from there, the impacts they have on the environment and on our health. I've added a Canadian context here. You can go around the clock. From the top, 12 o'clock, air pollution, Canada, asthma, cardiovascular disease are impacted. Of course, we get a lot of air pollution from our forest fires. Next on the list there, we have vector-borne diseases in Canada. That would be most typically West Nile virus and Lyme disease. Again, things which are moving north because of climate change. Allergy season getting longer and more intense. Down to waterborne diseases, we have these sorts of issues when things like the hurricane that I showed you, or some of the crazy things that have been happening in BC. We actually can have these waterborne diseases. At the bottom, forced migration, not seeing that as much clearly as the southern states is seeing. Mental health, climate anxiety. I'm going to skip up to heat stress for the elderly and vulnerable populations. This is actually the number one killer in Canada in terms of climate change is heat. And then finally, injuries from things like tornadoes. Next slide, please. So I'm moving towards solutions here. This is a study done in the Lancet 3 years ago, a landmark study. A ton of work went into this. This is the footprint of the entire English section of the NHS. This would include ambulances, dental offices, primary care hospitals. As you can see, transportation up there in green at 11 o'clock is only 10%. A bit of a surprise. We've been talking about transportation for years and years. Transportation is a tough piece of the pie to make smaller in Canada. We don't bike everywhere. I mean, with warming temperatures, there may be more of an opportunity to do that. The red piece of the pie is essentially what happens inside your building, which at 8 o'clock, that piece of pink there, 10% building energy. Another one, bit of a surprise, it's only 10, maybe 11% of the pie. What is the big piece of the pie? Supply chain, all of the stuff we buy. When I first saw this, this was a bit of a shock. I've now kind of got my head around it. The first 22% of the pie is actually the production of pharmaceuticals. Next slide, please. So we have moved this to a Canadian context. We published this 2 years ago. This is the low-hanging peach tree for essentially a 200-bed Canadian hospital. We encourage hospitals, if this becomes part of your, if you have a corporate green team, let's say, and you want to go after the big items, we encourage you to go after the orange items. We call these the game changers. They have over 100 tons of CO2 impact per year if you can go after these items. Some of them are higher up in the tree in terms of cost, the cost scale there on the left. If you look at the $10,000 mark, which is kind of maybe just a little above EV chargers, most of these items are cost neutral or cost saving. So much of what we do in sustainable healthcare does align with efficient healthcare and does not cost you money. In fact, many of these things are cost saving. Next slide. So I'm going to go through the 8 categories that we talk about. That again, if you're going to go after this as a team, these are the things you want to look at. Ideally, you have a strategy as a hospital or long-term care facility. And that can look any number of different ways. Lots of hospitals now in Ontario. I couldn't say this 2 years ago. There's only a few. Now there are many hospitals in Ontario who are developing a strategy and also assigning a person who's most responsible. Next slide. This is arguably the peach tree rearranged. Everybody wants an infographic these days. You basically translate everything so it's like grade 4 level. So here it is. Big print, little pictures. The bottom line is this came from a spreadsheet of about 50 items with about 7 of us thinking it through about 2-3 years ago about the math of what are the most important, most significant things you can do in your facility. So if you're going to take this on, go after the big items. And in blue, and again, probably hard to read, but welcome to the slides. In blue are the different parts of your hospital team that need to be at the table. It is not just the buildings and energy person up there on the top right. You need your food manager, you need your pharmacy lead, procurement lead who does the supply chain purchasing, education, choosing wisely. We certainly promote choosing wisely. All these different things are a part of becoming a green facility. Next slide. We just put this out about a month ago. The climate emergency, streamline your journey. And the idea behind this one was essentially taking those, what are 22 boxes you just saw, and we have narrowed it down to the top 10, and not top 10 in terms of greenhouse gases, although they're all big impact, but the 10 which are cost neutral or cost saving and are relatively easy to implement. Next slide, please. And again, difficult to see, but these are what we consider to be the top 10 things. The reason we did this, there are hospitals in BC which are a few years along their journey to becoming green facilities. And look, I don't need to tell you there are places in the country that have not started yet. And so we just want to help those places. This is something you can take on. These things are doable. These things will not break your budget. Again, you need a strat plan. One thing that we're actually showing there in that colorful ring is that if your hospital has foundation investments, moving those investments to what we call impact investment and moving away from fossil fuels is one of the things you can do. Procurement. Are you thinking what all of the things that you buy, are you adding either what you call ESG language or sustainability, environmental and sustainability language to those contracts? Pharmaceuticals deprescribing. Can you come up with a deprescribing program via your EMR or do a QI project and decrease your total prescribing? I know at my hospital, as I do work in health and health sciences, and I'm in the complex care division, my patients come to me. We did a QI project a couple of years ago on 19.1 meds each. Surely I can decrease 1 med, which would be 5% of meds. Food, can you switch? I'm not talking about a vegan diet for the hospital. I'm talking about shifting maybe 3 meals per week from meat items to plant-rich protein items, building energy, a couple of the usual suspects there. Next slide, please. Education, being a Choosing Wisely facility is important. Every single test we order does have a carbon footprint. I find as a family doc in the community, and I have a problem-based learning group I meet with every month. Those folks are on top of this stuff. If I say to my colleagues, can you decrease your x-rays by 5%? They would say, Miles, look, we're doing the best we can. If we decrease any more, we're going to miss a diagnosis. However, I think in the hospital setting, we do see that, someone comes in and it's just automatic to get the CBC done every single day. I think there's a lot to be gained in the hospital setting. Can we develop a culture of sustainability within our healthcare settings? And it might be something as simple as adding sustainability to our agenda. Next slide. So this is to my point, every test has a carbon footprint. This is not kilograms of CO2. As I mentioned, this is energy, this is kilowatts per hour, which can be easily translated to kilograms. So you see where an MRI, CT, X-ray sit here. This was done by some U of T med students. Next slide. And here is the actual carbon footprint from different articles around the world. The footprint of a transfusion, of a CBC, of an abdominal ultrasound, it looks like I've got there, and kilograms of CO2 for an admission. We did a study on this in Canada. Those are our numbers at the bottom, different than the American numbers because our grid is different, our electrical grid is different. Next slide. We do, in terms of education, we do have webinars. So this is a little promo for our webinars. We will be doing at least a webinar every month from the coalition, and these are some of the ones that we do. We do a nursing month webinar every year, pharmacy month. We'll be talking about our Green Teams initiative, which is funded by Environment and Climate Change Canada. I will be talking about a study which is about to get published called Journey of a Pill. Next slide. So supply chain, I've already touched on this. The 4 R's, we're all familiar with the 3 R's. We add the 4th R, which is refuse. You can refuse what I would call the bad products. And I talked about a mask, a gown, same thing, single-use gown, again, dug out of the ground, shipped, manufactured, shipped, packaged, shipped, used. I can use a gown for as little as 1 minute, depending on what I'm doing, then thrown out. Reusable gown can be used 80 times. Engineers have done a robust study comparing the reusable gown to the single-use gown. I do get asked this question, hey, the reusable gown does need to be washed, etc. It's not even close when you look at that study. Reusable gown, much, much better. And I know there's engineers in McMaster who are looking at making the gown which can be used 200 times. So we need to be switching to what is called a circular economy from our traditional linear economy, where we dig things out of the ground, use them once, throw them out. We need to find ways to circulate things. And as I mentioned before, the solution here, Hamilton Health Sciences did add sustainability as one of their pillars about 2 years ago now. So it is now part of our strat plan. It has allowed our procurement lead. Hamilton Health Sciences, the second biggest buyer behind UHN in Ontario. Our procurement lead sent a letter out to 1,000 suppliers 2 years ago to say, hey, heads up, we want to start buying green products. And then 6 months later, started to add that into our RFPs, adding environmental language instead of simply cost and quality, which of course also matter a ton. Next slide. I'd like to show this one to give you an idea of what we buy. Everyone in our society buys computers. This is, I suppose, a generic slide, not just for healthcare. This was done by the Copenhagen Business School. This was done during COVID. I think their goal here was not around sustainability. It was actually more around resiliency in terms of supply disruptions that we were seeing during COVID. And there are 2 pathways they show here. One starts in Chile, raw materials being dug out of the ground. Number 1, shipped across to Southeast Asia. Number 2, shipped further north into Asia. Number 3, shipped into China. Number 4, and then across to Mexico for packaging and installation, and finally up into Canada to the consumer. This is typical for the products we buy. Next slide, please. We do have what we call a sustainable procurement group. If you're interested, let us know. It's kind of the crazy stuff I do. I think it's 2.5 years ago now when I realized what a big deal supply chain was. And as you all know, we don't learn about this in medical school. But I started phoning the large hospitals in Ontario to speak to their procurement folks and say, hey, do you realize that you might be the biggest piece of the puzzle here for sustainable healthcare? This was at the end of COVID. They might have sworn under their breath. I don't know. They were trying to get Tylenol to their hospitals. I don't know if they wanted to hear this, but I must say 90% of them joined this group. We meet every 2 months. We're continuing to meet. We have an educational session, and we also discuss how can this be done? How can we move this along? And we have groups like Supply Ontario who are involved with this, and Mohawk Medbuy, for example. Next slide, please. Drugs and devices, you have probably heard about meter dose inhalers. For example, one Ventolin inhaler being equivalent to a 140-kilometer car ride. That's the number I use. I see some people using as much as 170-kilometer car ride. I've heard recently maybe it's only 100, but in any case, it is one med that we know beyond the production of the med also has emissions in its direct use. Imagine if in your hospital you have someone come in to emerge and they need an inhaler for whatever, COPD, asthma, they get admitted. Does that inhaler follow them to the ward, or is it thrown out and emerge after 6 uses? Some hospitals simply throw the MDI out and then get a new one when they're admitted. So, I mean, there's things like this that we can be doing. I mentioned deprescribing. In terms of cost, for the 200-bed hospital, clearly depending on what elements your hospital has, what wards your hospital has, can be as much as a $10 million budget. So a 5% decrease is huge for your budget. The QI project I mentioned, my colleagues at St. Peter's loved me for doing it. It was a group QI project. They really didn't need to do much, and they got their CPSO credits. Next slide. When I saw that graphic of the computer traveling around the world, I was curious. I Googled, what is the life cycle of a medication? What's the journey of a medication? And you are not going to be surprised to know there was not much information out there. Big pharma is extremely important in our sector. It is also very secretive in terms of what goes on in those buildings. I liken it to Charlie's Chocolate Factory. We really don't know what goes on in those buildings. We also don't learn much about excipients in medical school. I certainly didn't. We learned about the active pharmaceutical ingredient, the API. As it turns out, looking at clonazepam here, I took this off a website. I took off the names of the companies, and I put 4 different companies up there, A, B, C, D, and I put down the excipients they use to make a clonazepam pill. One company uses as little as 5. Another one uses as many as 9. There's a lot of products that go into making a pill. Next slide. Thanks, Kathy, by the way. So this we published, actually it's in preprint. I think the preprint is called The Long Journey of a Clonazepam Pill or something similar. We hope this is going to get published very soon in a bigger journal. This is too small to read, but you get the idea. At the top, there is the API, which is produced in India. The excipients come from China in green. The API actually needs to be shipped over to Europe to be tested because clonazepam is a restricted med, Then it is shipped back incredibly to India, where it meets up with the excipient and the tablets are made. Then it is shipped all the way across to New Jersey. And there's a process that needs to go through in New Jersey. In some cases, it's shipped as far as California for sort of sub-tableting. Can be any number of places on the East Coast, then up to Oakville or the Greater Toronto area for redistribution, across to Vancouver to the consumer who urinates it out, and it ends up in our water. Next slide, please. So we all know about deprescribing or medication optimization. We need to be careful as physicians about how we do this. We do have a sustainable prescribing working group, similar story, reaching out to all the deprescribing groups across the country 2.5 years ago. So we've all come together, made this toolkit on the right. Again, you're welcome to see that, which was called Options for the Sustainable Prescriber. That's for outpatient prescribing, and made this toolkit with Cascades, which is on the Cascades website and the Canadian Coalition website, about how to optimize medications in an inpatient setting. Next slide. Transportation. It used to be that a bike-friendly facility was what I call the queen of green, still super important. Great to put your bike rack storage facility at the front of the facility to show that you're doing this. But now virtual medicine has probably become even more significant, especially for rural hospitals where people might have to travel quite a bit to a clinic or to the hospital. Is virtual medicine possible? Can it be done safely? How can we do it safely? Next slide, please. And conferences. I always advocate for the virtual conference. This was a virtual conference in England from 2020. It was a pharmaceutical conference. The people who stayed in North America on the right, a total of 10 kilograms of CO2 to use the internet in their office. For those who flew over to the conference, you can see the impact of the airplane, big circle there, roughly 1,900 kilograms of CO2. I'm not saying don't fly. I'm simply saying we need to advocate for virtual conferences and take advantage of them when we can. Next slide, please. Food is a big one globally. It is thought to be one of the biggest, and I'm moving away from healthcare here. I'm talking about all global CO2 production, that switching to plant-rich eating and decreasing our food waste are the top two solutions in the next 30 years for decreasing global footprint. And what can we do at a hospital? As I mentioned, we can be shifting the menu. There are lots of examples. The whole Peach Health Initiative, how we started 3 years ago, was simply looking around the province and saying, who are the superstars? There's superstars all over the province doing great things in surprising places. It just so happened that Oakville at the time, I think it's still true, has done the biggest shifts toward plant-rich eating. They also spent a lot of time sourcing locally. I think plant-rich, their menu is 35 to 40%, if I'm not mistaken. So this can be done, and it's a big impact. Next slide, please. And this is why it's a big impact. This, again, using kilograms of CO2, is the impact of different servings that we would have at our meals. Beef on the left, cheese breaks my heart up there as well. A pescatarian diet, quite a bit of a drop down there. You see the fish, and then you're moving into all the plant-rich items. And so the moral of the story is eat more broccoli. Next slide, please. We just made a business case for hospitals. This is a bit of a longer read, but you can look at the table of contents and zoom into what you're interested in. Spent quite a bit of time making this with what we call our Peach Food Group that meets every 2 months. And we also work very closely with Nourish. Nourish is a national group that's been around for about 12 years that looks at adding more plant-forward menus to hospitals and to healthcare. So take a look at that. There's a big study out of New York City which showed that a plant-rich meal is 60 cents cheaper than the alternative. So that is a lot of money over the course of a year. Next slide. Natural systems. My journey in terms of greening healthcare actually started with trees. Co-founded a charity called Trees for Hamilton. What is that? Maybe 12, 13 years ago now. We do a lot of community plantings. I think we've done about 85 community plantings now. We plant about 4 times in the spring and 4 times in the fall. We aim to plant in the inner city where the hottest areas are and where the least trees are. That was surprisingly difficult despite all the opportunities. When you go around downtown Hamilton, you see all places, all kinds of places. There are many barriers, including people who live in an area near a park or parkette who don't want trees because they're worried about crime. I think that's a myth, but long story short, we found that one of our best partners was healthcare. Of course, there's a lot of healthcare sites downtown in Hamilton. We have St. Joe's, we have Hamilton General, St. Peter's Hospital, where I work. So we did start to partner with the health facilities and plant at those sites. Next slide, please. There are many health benefits of trees. You can read some of them there. If you are interested in this, there's an amazing website out of University of Washington. That's Washington State. I put the link down there on the bottom, www.greenhealth.washington.edu. They list all the studies which show the benefits of not just trees, but greening spaces over the past 40 years or so. Next slide, please. This was our first planting at the Hamilton General. Our goal was to plant about 12 or 15 trees in the first year, even though the General takes up a full city block. If I'd done the walk around the first year and tried to decide how many we could plant, it probably would have been as many as 80 trees. We did not want to put 80 trees in the ground the first year and find out that they were getting stolen or trampled, or that we were planting the wrong species. There's lots of salt spray downtown. So we planted 15. This has become an annual thing. We have now planted over 60 or 70. The first year we got out the gold shovel. Again, one of the studies that was done years ago by Ulrich, it was a surgical ward, I think in the States, that was primarily post-op open cholecystectomy. It sort of tells you how old that study is. And the folks who were on the east side of the ward looking at a brick wall had worse outcomes in every measure than the folks on the west side who were looking at a field with trees in it. And there's further evidence from that. So that is really the spirit of what we're doing here. Next slide. This is the hospital I work at. It's a 100-year-old hospital. It was already beautiful long before I got there, but we've added 15 more trees every year. It's a fun thing. Again, this is the pharmacist I work with on the left and the nurse practitioner I work with on the right. And we have added probably 70 trees to this site as well. Next slide. This is St. Joe's Hospital in Hamilton. These are 3 people actually from the leadership team. The one on the far right is actually their vice president of their corporate green team, Karen Langstaff. Next slide. And we planted long-term care facilities. This is a site on what is called Hamilton Mountain, which has 4 acres. So it was a great opportunity. We actually, they wanted 40 trees in the first year. So that's what we did. Doctors and nurses came out, and you can see that they brought out there in the top couple of photos there, brought residents out to watch because it was a lovely day. And so we think about what we're planting. We put some privacy trees in to block things they didn't want to see. And we brought in trees like Eastern Redbud, which do bring berries and birds, which is nice for people to look at out their windows. Next slide. I suppose before I move on, if you want to do that, let me know. We now have a national initiative. Reach out to me. I will flip you to someone in our group. All we need is a champion at any site, and then we partner you up with a tree or pollinator group. So I'm moving briefly here into the office section for any of you that have offices. As Kathy mentioned at the beginning, it's almost 2 years now, time flies by, that I've been the executive director of the Canadian Coalition for Green Healthcare. The Green Office Toolkit on the left obviously precedes my time there. I think there's about 5 founding physicians who are involved with that. This field that I'm talking about today is in its infancy, which is kind of incredible. So over a 5-year period, 2023, we did a major redo on this toolkit because there was so much more information. Next slide, please. This is a table of contents. I tell people this is a longer toolkit. This one, gosh, what is it? 50 pages or so. We reached out to people across the country who had, interest in a particular area. Melissa Lem, for example, with the PARC prescription. So she wrote a one-pager for us. So it's a whole series of one-pagers. I tell people, look at the table of contents. Make it a bucket list. You're not going to do everything in the first year. What are you passionate about? Where's your skill set? Maybe you can take on one or two things in the next year. Next slide. So I showed you that NHS pie graph, which had supply chain being a big percentage, and it had medications at 22%. This is the primary care clinic. If you take that same data and translate it to a primary care clinic, and as you can see in the purple table there on the left, I've crossed out anesthetic gases not used in primary care and just left MDIs. And on the right, pharmaceuticals, the production of pharmaceuticals is actually 48% of the footprint of primary care. And in addition, the emissions from MDIs are an additional 13%. So you can see what we need to target in primary care. Next slide. If you do look at that pie graph, there's a couple of things which are not mentioned in that pie, which is essentially the advice we give as physicians. And I don't think I'm going to get to this in the rest of this presentation. I'm just going to mention it now. Plant-rich eating is something that we have an opportunity as primary care docs, and certainly a lot of specialists have this opportunity too. When a patient comes in with a new diagnosis, comes in with obesity, diabetes, new heart disease, there are opportunities to have these conversations with patients and talk about their what they're eating. And if you look at the new Canada's Food Guide, which is not terribly new anymore, it really is a plant-rich eating now, which is better for planet and better for patients. Also, end-of-life care. We have a chapter on end-of-life care, and I'm going to get to why in just a second. Next slide. I often start my lectures now with this question, which seems a little bizarre when we're talking about sustainability. And we can even stop and reflect here, and I'm going to have a little drink of water. Where do you want to be when you die? And if this was live, I would ask for a show of hands, and I would ask, who wants to die in hospital? Who wants to die in long-term care or a nursing home? And who wants to die at home? And so far, I've done this about 4 times. No one has put their hand up for hospital yet, but we all know as docs, there are reasons that you might want to die in hospital. In fact, the hospital I work at, I believe, has the biggest palliative care ward in Canada with 60 beds. So I certainly do that type of medicine. But no one puts their hand up for that. A couple people put their hand up for nursing home. Everybody puts their hand up for home. Next slide, please. I mention that because this is patient-focused care. We don't want to age and die at home, but we do want to age and die at home. We do not want to age and die in hospital. This is part of the Lancet study we published 6 or so months ago. These graphs are not going to surprise you whatsoever. Top left, polypharmacy by age, starting with babies on the left and maybe 90-year-olds on the far right. Polypharmacy clearly goes up with age. The green bar, the blue bar, one is 5 meds, and the other one is 3 meds, depending on the definition you want to use. Second one over, top right, again, babies to the elderly, babies far left. This is cost. This is health expenditure by age group. We looked at 2019 because we wanted to go pre-COVID with the data. As physicians, you're not surprised to see that babies use a lot of healthcare dollars. Vaccinations, maybe half a day in hospital or a day in hospital, a bunch of baby visits, and then it drops right down all the way up until we're about 45 years old, and then the cost curve goes up. Why am I showing you a cost curve? the cost curve is directly related to the greenhouse gas curve. We don't have a greenhouse gas curve for this data, but if you are using resources, you're using greenhouse gases. So that, not surprising, this goes up. Bottom left, same thing, same curve, hockey stick curve, days in hospital per year, tiny bit for babies on the left, then flat, then at 45 starts to go up. My big point here is that if I was to ask you all right now, why is this curve going up? I think a lot of us, without thinking terribly deeply about it, would say chronic care, chronic diseases, and that is true. But I think a bigger piece of this is what we see on the bottom right. At 45 years old, sadly, the bars start to go up in terms of our mortality rates. And so now we're getting into the last year of life and the final 3 months of life, which again follows those same curves. Next slide, please. Why is this relevant to sustainable healthcare? So part of this study, we looked at data from Fraser Valley, BC, because they had this data, and from a study which was done in Laval, an extensive study on the greenhouse gas emissions per day in hospital and per day in long-term care. So on the left, Fraser Valley, 30 kilograms of CO2 per bed per day. Fraser Valley has what they call mixed sites. BC has mixed sites, which have long-term care beds within the hospital. Jump down to long-term care, 8 to 9 kilograms per bed per day, and home care less than 2. So that is why this is a planetary health issue. This is a patient issue. This is a cost issue. This is a hospital crowding issue. It's also a sustainable healthcare issue. Why is Quebec different than BC? Quebec has an almost perfect electric grid at over 99% because of their hydro dams. Next slide, please. Finally, this is from 10 years ago by a palliative care researcher in Toronto, looking at the final year of life by quarters. So at the left, the first little pink dot I've got there is 360 days before death, clearly a retrospective trial. The black line, importantly, is the total cost. Again, we're looking at costs here. Stays flat till 180. Then really at 90 days to go, that is when the cost curve goes up in a big way. And you know, I think this is because we're in hospital at this point. We're getting investigations done. We end up often in the ICU. A study which was done, this isn't me asking people to put their hands up, 87% of Canadians want to die at home, but I think it's 59% of us die in hospital. Next slide. So what I'm getting at is that a lot of the sustainable healthcare stuff, so there's all the things that I showed you on the Peachtree, all the things on that checkbox list that we can do to make our hospitals more sustainable. But another big piece of this is we need to decrease length of stay in hospitals. In Ontario, we're talking about Ontario here, 18% of our acute care beds are alternate level of care beds, patients being discharged already, stable to go home or to long-term care, but there's no place to go. Our solution, I think, typically is to build bigger hospitals. I think our solution needs to be to make home care more available and robust, and we need a bigger primary care system. Of course, I'm biased as a family doctor to support home care. Next slide, please. So, in my mind, environmental sustainability aligns with excellent patient care, with an efficient system, and with cost savings. Next slide. I think that's it. So here are a few people you can reach out to. We have a hospital green teams project. June, who's an RN, is running that program, June at greenhealthcare.ca. That is a national project funded for the next 3 years. If you are interested in planning a tree at your facility, it is Sam at greenhealthcare.ca. Again, I'm both with Peach Health Ontario, which is provincial, and with the Canadian Coalition for Green Healthcare. I put the Peach Health Ontario website there. It's easy to look up. And if you look under our impact, you'll find all the various resources that we've made. thank you so much for inviting me and for your time today. And thank you, Kathy, for flipping through these so nicely. And also, Kathy, big shout out. You said Peach Health Ontario without any kind of stumbling, which is really rare. Hi, Mylene, how are you? I haven't seen you in a while.
Hi, good to see you.
Yeah, nice to see you too.
Thanks for the amazing talk. That was so good.
Okay. Yeah, thanks for joining. So I didn't see any questions in the chat. It's too bad when you're doing these. I work off my phone, and you sort of see when people come in, and you see when people leave. And I did see a few people left in the first 10 minutes. Hope it wasn't boring and I didn't turn people off. Maybe I should start with the end, which is to say that environmental sustainability aligns with everything we're doing. Don't run away. Anyhow, Barb.
Hi, thanks for this. It's enlightening. So back in 2017, the West Prairie Sound Health Center here actually created a green team.
Yes.
And we started a number of initiatives. So
Mhm.
we've done the lighting upgrade, we've done the boiler upgrade, we've got our water refill stations, our bike stations, our reusable gowns we went to,
Awesome.
our reusable sharps containers that we went to. I do believe that we're still doing the OR pick list by surgeon. I know at one time when I oversaw MDRD, we were doing it that way. Our HVAC system has been upgraded. We've got the battery program here where we collect our batteries and they are picked up for disposal. And from a food services perspective, we do food waste audits. So while we may not be using a plant-based menu, we do track our waste and then we curb our production. So we are trying as best we can to minimize that. The West Prairie Sound Health Center is attached to our long-term care facility, which I'm also privileged to manage, and I manage the food services over there. So I work hand in hand with the food services team here. One of the things that I am.
Sorry, can I just interrupt and say
Yep.
that's amazing? You are doing amazing stuff.
Thank you.
Did you ever go or enter into the Green Hospital Scorecard? And that the coalition started that 2014, long before my time, and has a Green Hospital Scorecard.
No, I did work with a
every-
gentleman. Sorry, I think his name was Keith from
Kent.
Kent from Green
Yes.
Healthcare. Yes.
Yeah. He's a co-founder of. Yes. Okay.
Yeah, I
Yeah.
did work.
Look, it sounds like that award is done based on hospital size. It sounds like you would do very well. I almost want to ask you, what boxes have you not checked? Because it
I've
sounds like
got
you've
them.
checked. Okay.
And I want some, so
Okay.
I would like to.
Yeah, go ahead.
So one of the big ones that I'm looking at right now, and I've been working with a vendor on this, is I'm also responsible for procurement here at the hospital.
Okay. Wow.
Is,
Yeah.
and this might be interesting for some on the line, is our toilet brushers. So we currently use approximately 70 toilet brushes a month, which are thrown into our landfill. So I'm not sure what other hospitals are doing, but I'm hoping that one of our vendors is going to come up with a solution for us in the very near future where we do away with the bunny tails on them and we have a reusable head that it's just going to be the head that's thrown away and not the whole toilet brush. And then the other thing that I'm hoping we'll see in the near future are some green products for cleaning and disinfecting, sanitizing and disinfecting, that have the efficacy to kill the pathogens that are coming. I know that there's some out there that kill approximately 20 pathogens right now, but unfortunately they will not kill all of our bugs that we encounter in a healthcare setting. So I'm hopeful. I don't know if you have any insight into that, but those are my two things that I wanted to ask about.
All right. Well, first one, never been asked, but yeah, happy to take that on. So I have not heard solutions about toilet brushes. I am guessing that you work with Mohawk Medbuy.
Yeah, we're part of that GPO as well as Health Pro.
Right, right. Yeah, so I sort of followed, I'm sure as we all did with interest, how Mohawk Med by basically bought up all the so basically they are 90% of our, healthcare supplier now. If you have a contact there, I would ask them about that. And Barb, you are more than welcome to join our meetings if you want us me to send you our link. We're about to make an announcement about these meetings. I can't make it yet, but would be great to have you. And in terms of sanitizing, disinfecting, sorry, were you talking about washrooms, or were you talking about any place?
Anything. So we went to a ready-to-use product, but we have we keep our containers as much as possible and put a refill into them, as opposed to our diluted wall solutions. And the reason for that is that products that sit in open water, they lose their efficacy, and the housekeepers were known to fill their buckets in the morning and then never refill them. So they were literally just washing things with water. And when we moved to the ready-to-use product, our healthcare acquired infections decreased. So while there's a bit of a carbon footprint to that, it's actually less, by what I'm told by our vendors, than using the bulk system. So
yeah, so again, I'm going to defer to it. Look, if you'd like, feel free to reach out to me. You can reach out.
Sure.
Look, I'm no surprise. I'm Miles at greenhealthcare.ca, Miles with a Y. So
Okay.
reach out to me and I can send you to Kent or Linda. I have lots of mentors who can get me to the right information.
Perfect.
The one thing that comes to mind when you ask that question is UV lights in washrooms, which was done in one hospital. I'm not supposed to say which one, but there was a hospital in Canada which was having repeated C. diff outbreaks in a column. Obviously the toilets are all in a column from floor to floor, and they kept getting outbreaks. And then they switched to UV lights, and they did not have a problem anymore. And that supposedly is the best. Like most of the stuff is coming from the shared washrooms, right? So that's a really interesting solution. Obviously, a capital cost,
Yeah.
but then you are decreasing your your hospital infection rates. And I need to apologize. I do have another call at 1. I saw one other question there, and I'd actually love it if that person would send me an email again at Miles with a Y at greenhealthcare.com. And I will, and that question is, are there other small hospitals that are doing good work? And there certainly are. And I would say you folks are as well. But I could certainly find out who's done well on the green scorecard in the past for small hospitals and get you in touch.
There was actually a second comment as well.
Okay. And what was that?
What about cleaning wipes? I assume a face cloth with liquid alcohol is better to use to clean our stethoscopes than the ready-made antibacterial wipes.
Gosh, so many questions today I haven't heard before, but I would assume that's true. I look at that, that's a reusable. So I would assume that's true. Yeah.
Okay.
Yeah, look, and if you've missed anything, feel free to send me an email with any other questions. Have a great holiday, everybody.
Thank you so much for presenting to our team today, Dr. Sargent. And
Yeah, thanks again for having me.
you're welcome.
Thank you, Dr. Sargent.
Thank
Yeah.
you.
Yeah, take care. Nice to see you, Mylene.
Nice to see you.
Yeah. Yeah, bye-bye.